Hello, my name is Archit Garg, and currently I am a second year internal medicine resident at St. Peter's University Hospital in New Brunswick, New Jersey. It is an honor to discuss our recently published article titled Endoscopic Band Ligation versus Argon Plasma Coagulation in the Treatment of Gastric Antral Vascular Ectasia, a systematic review and meta analysis. This article was recently published in the Journal of Gastrointestinal Endoscopy, GIE. This paper involves the equal contribution of my co-authors, Vishali Moon, Khyati Bidani, Archit Garg, Arkady Broder, Babu P. Mohan, and Douglas Graham Adler. This was a study we conducted to address the clinical questions regarding the management of gastric antral vascular ectasia. Gastric antral vascular ectasia account for 4% of the non-varicose bleeds. Recurrent bleeding episodes associated with gastric antral vascular ectasia result in chronic iron deficiency anemia. Studies have shown that about 70% of these patients with cave from the recurrent bleeding episodes are transfusion dependent. Hence, management of cave is important and endoscopic management remains the cornerstone. The most commonly used endoscopic management options include argon plasma coagulation and endoscopic band ligation. Argon plasma coagulation has traditionally been the standard management option for the treatment of cave. However, recent studies have shown promising results with endoscopic band ligation. Hence, there is an ongoing debate regarding what is the superior method in terms of the efficacy as well as the safety. Hence, there was a clear need for us to perform a systematic review and meta-analysis to consolidate the available data and provide clarity on the best endoscopic treatment option for GAVE, address disparities in the existing research, and support evidence-based medicine decision making. In our study, we analyzed 10 studies, which included 476 subjects. Out of those, 197 underwent endoscopic band ligation and 279 underwent argon plasma coagulation. Among the outcomes analyzed, the eradication rates were significantly more with endoscopic band ligation, 88.6%, in comparison to argon plasma coagulation, 57.9%, with a pooled relative risk of 1.52. The bleeding recurrence was significantly lower with endoscopic band ligation, 6.6%, in comparison to argon plasma coagulation, 39.7%, with a relative risk of 0.21. Similarly, the recurrence rates were also lower with endoscopic band ligation, 7.3%, in comparison to argon plasma coagulation, 38.5%, with a pooled relative risk of 0.22. The mean hemoglobin in the endoscopic band ligation arm pre-intervention was 7.83, while post-intervention it was 9.9. In contrast, in argon plasma coagulation arm, the mean hemoglobin pre-intervention was 7.9, while the mean hemoglobin post-intervention was 9.84. The standard difference of pre versus post-intervention hemoglobin was significantly more in endoscopic band ligation in comparison to argon plasma coagulation. The hospitalization rates were lower in endoscopic band ligation, 0.67, as compared to argon plasma coagulation, 1.673. Similarly, the transfusion requirements were significantly lower in endoscopic band ligation, 1.24, as compared to argon plasma coagulation, 3.098. Moreover, our study also showed that the mean number of sessions required were lower in endoscopic band ligation, 2.31, as compared to argon plasma coagulation, 3.95. In conclusion, our study showed that endoscopic band ligation demonstrated better eradication rates with fewer treatment sessions required, lower bleeding recurrences, hospitalizations, and transfusion requirements. Further research is definitely required in the management of gastric antral vascular ectasia. This includes comparison studies of endoscopic band ligation and argon plasma coagulation with the newer treatment interventions available, including radiofrequency ablation, hybrid argon plasma coagulation, and the combination of polidocanol and argon plasma coagulation in the management of GAVE, because not many studies are available which have evaluated the effectiveness of the newer modalities. Moreover, cost effective analysis of all the above mentioned studies are also required in order to see which one will be most appropriate in the hospital setting. Another area which requires further research is long term outcomes of endoscopic band ligation and argon plasma coagulation, for which observational studies are required. To sum up, our analysis shows that although argon plasma coagulation has been used as the first line option for the management of gastric antral vascular ectasia, endoscopic band ligation can be considered as a good first line alternative for the management of GAVE. On behalf of all the authors, I would like to thank the Journal of Gastrointestinal Endoscopy (GIE) for giving us the opportunity to present our research and participate in this author interview series. We hope that with our meta analysis, we are able to provide more data to help support the clinicians in their decision making in the endoscopic management of GAVE, and we also hope that our meta analysis guides further research on comparative analysis of endoscopic band ligation, argon plasma coagulation with newer management options like radiofrequency ablation in terms of long term outcomes like efficacy and safety, cost effectiveness, and patient characteristics that might guide the different treatment options.